My name is Alice Domar. I'm a psychologist. I am the executive director of the Domar Centers for Mind-Body Health at Boston IVF. I'm a senior staff psychologist at Beth Israel Deaconess Medical Center, and I'm an associate professor part-time of obstetrics, gynecology, and reproductive biology at Harvard Medical School. And I'm going to be discussing decreasing the emotional burden of care for infertility patients. The psychological aspects of infertility and infertility treatment do not constitute any formal part of the training of REIs in this country. Most mental health professionals employed by infertility centers or used as consultants have as their main role the assessment of patients and individuals involved in third-party relationships. Thus, there are minimal interactions between most infertility physicians and mental health professionals in the care of most patients, since the vast majority of our patient population undergo treatment with their own gametes. This needs to change. There has been increasing attention amongst our European counterparts to what they have termed the burden of care. The burden is very important in every facet of care, but it's really specifically relevant in three main areas. The first is the distress of our patients, specifically anxiety and depression. The second is distress causing treatment termination. We know that distress is the main reason why patients drop out of treatment if they have insurance. And the third is the impact of patient distress on those who care for them, specifically nurses and physicians. Infertility patients are very distressed. As you can see here, the most recent research by Laurie Pash, a psychologist at UCSF, points out how very distressed they are. In a large study of patients receiving treatments at one of 5 centers in California, 56.5% of the women and 32% of the men scored in the clinical range for depression, and 76% of the women and 61% of the men scored in the clinical range for anxiety. Another recent study documented the intensity of depression in infertile women. Almost 10% reported significant suicidal thoughts. Ironically, patients care more about the quality of their care than they do about conceiving. And they care more about the quality of their care than their physicians know. Patient-centered care is vital, and we truly underestimate how much of a difference it makes to patients. Most physicians believe that patients drop out of treatment for 2 reasons. Either they don't have their money to continue, or if they do have resources or insurance, they drop out primarily because their physician recommends it due to their poor prognosis, which is also called active censoring. In fact, uninsured patients do indeed drop out because of financial restraints. However, active censoring is a relatively uncommon reason for treatment termination. The most common reason is actually stress, now referred to as treatment burden. All of the research published has shown this. Insured patients consistently report that stress is the primary reason why they drop out of treatment. Patient distress is also a burden for the healthcare team. Anxious patients do not retain information, and they thus tend to call with the same questions and concerns over and over and over again. It is really challenging to care for highly distressed patients who tend to be young and healthy. Research shows that the distress level of infertility patients is equivalent to the distress levels of women with cancer, HIV-positive status, or heart disease. But young women tend to be more assertive about their care, especially if they're paying out of pocket for it. There are so many ways to decrease patient burden, including offering tailored educational materials, screening high-risk patients and recommending mental health services for them, offering psychological interventions, and involving their partner more. A recent meta-analysis on 35 studies on psychological interventions for infertility patients showed that those who participated in some sort of intervention were associated with significant decreases in psychological distress, as well as significant increases in pregnancy rates. Recent research also shows that decreasing distress can be associated with significantly lower dropout rates in insured patients. We need a new model of care for our patients.